So if each of you could introduce yourselves, tell us your name, your latest books, and what you've been doing the last 20 years so we can get a little clearer picture of yourselves. And we could go in order. Why don't we go with Dr. Montgomery, Dr. Laster, Dr. Kahn, and Dr. Am I pronouncing it right? Pasricha? Okay, good. Okay, let's do that order.
Good. Hi, good evening, and thanks for having me. It's always a pleasure to be here, The Real Truth About Health. I'm a board-certified cardiologist. My background's in cardiology and cardiac electrophysiology, and we've managed patients with advanced heart disease for many years. And we've applied an integrative approach to managing our patients. Lately, we've focused on the application of optimal nutrition in the management of patients with acute illness. And we have clinical studies that we've published in the medical literature showing that optimal nutrition is effective in patients who are acutely ill, even at a point of being hospitalized in the ICU. My book, The Food Prescription for Better Health, talks about this from a philosophical standpoint. We have a nutrition center that's about 4 miles south of the world's largest medical center. And we manage patients both in-house, in hospital, and in our center, as well as at home with advanced heart disease and other chronic illnesses. And we're in the process of launching a new study where we're collaborating with Georgia State University. And we'll be looking at the biochemical effects and genetic effects of optimal nutrition in patients with coronary disease. So we're excited to get this study off the ground and look forward to sharing the results with the world.
Thank you.
Hello, everybody. Thank you for having me as well. It's a pleasure to be here tonight. Let's see, gastroenterologist here in Washington, D.C. And really my passion has been in nutrition and sort of gastroenterological health and trying to get patients to help with obesity and sort of initially being in general practice and seeing sort of the same thing over and over again and not having any time to help those patients sort of to deal with those disease processes. It's very common symptoms. And that's sort of where my practice came from, gut theory, total digestive care. And being here to be able to help patients actually understand nutrition, understand symptoms, understand sort of actual how to lose weight and sort of keep it off. And so that's me here in DC.
Thank you.
I'm Joel Kahn. I'm a medical doctor, triple board certified. I'm a professor at Wayne State University in Detroit, Michigan. I had the distinction at age 18 for realizing that the food in the University of Michigan dormitory was horrible, and I became a completely whole food plant-based human at age 18. And 45 years later, I've not fallen over in malnutrition or chronic diseases. It's worked out very well. So as I developed an expertise in interventional cardiology, heart attack treatment, and stents, I was teaching my patients about Dr. Ornish from 1990 on, and ultimately Mr. Pritikin, Dr. Esselstyn, and the whole wonderful leadership that we have in the medical research arm of nutrition and cardiology. And similar to Dr. Montgomery, just so completely astounded by the results that could be achieved. About 6.5 years ago, I completely focused and concentrated on my clinic, Kahn Center for Cardiac Longevity, to bring lifestyle cardiology and nutrition cardiology and sleep cardiology and stress management, and have a wonderful group of patients all over the world. And we just have a tremendous time trying to come up with the root causes of why people are suffering and correct them as much as we can and get them back to natural health.
Thank you.
I am on a treadmill desk in case anybody's wondering.
All right, I'll introduce myself. My name is Dr. Sarina Pasricha, and I'm a board certified gastroenterologist practicing in a private practice group in Delaware, which is my hometown. And my interest in nutrition kind of started early. I studied nutrition when I was in college, but really I would say it took on a whole new level when I became a mom. I have 3 girls, 3 daughters, and after I was pregnant with my first, I started to try and do some research and figure out what type of foods should I be feeding my daughter to try and set her up for success and a good, healthy foundation. And that's really where my journey began to really understand how important is gut health, the gut microbiome, how important what we eat is for our kids, for us, for pregnancy. And as a gastroenterologist, I see lots of patients, suffering with GI issues. And I started to see that they were grasping for anything to fix their diseases. And once I started to delve into the research about whole food, plant-based diet and lifestyle management, I realized that's really the key way to fix a lot of the GI issues that I see in my practice. So that was kind of my journey. Thank you for having me here today.
Thank you as well. Okay, so I'm going to ask two questions, one for the cardiologist and one for the gastroenterologists, and you could each answer what you could, and everyone can answer whatever they want to answer. So the question for the cardiologists, and this is the biggest question we could ask possibly about health in the entire 17-day conference. It's the number one home run question that's more interesting than any other question we could possibly ask, and that is, what % of heart disease and stroke deaths could be reduced by an ideal diet and lifestyle? So let's call it heart disease, stroke. Yeah, heart disease and stroke. What % of the deaths from those two could be eliminated if we had an ideal diet and lifestyle? So that's the cardiologist question. And then the gastroenterologist question, and I want to point out that the real truth about health has been focusing on obesity, diabetes, heart disease, cancer. For some reason, we never really focused on gastroenterology until I guess we started realizing that this was a huge issue that everyone was talking about and dealing with. And we said, we really need to address this. So we're very grateful to have you. So we kind of need a basic on, we're not sure, a lot of us, the difference between constipation, GERD, gas, Crohn's, IBS, leaky gut, SIBO, diverticulitis, dysbiosis, colitis, bloating. So maybe you could start by just explaining what these things are, and then also answer the same question, how many of these can be solved by ideal diet and lifestyle? So those are the two questions.
I'll start with the cardiology question. It depends on where you start, but let's say if I take your question, if we were on an ideal diet, if the ideal diet was universally ideal, from birth, childhood, pregnant women, et cetera, if it was ideal universally, then I think practically speaking, these cardiovascular diseases can be totally eliminated. So I would say something on the order of 100%. So if you were in an ideal diet, now that's an asymptotic line, of course. So the point of that is to say that the foundation of these chronic illnesses that we deal with is based on biochemical and physiological imbalances that are by and large contributed to by the diet. Now, you also have to look into the other aspects of life, how well we sleep, how much we exercise, and all of these things. But the reason why I gave diet the center point and say we can reach 100%, because if we had an ideal diet, then I think we would all be in the framework to exercise more, in the mindset to consume less toxins such as alcohol and cigarettes and the like. So I attribute an ideal diet as being a cornerstone to contributing to all of these other lifestyle factors that are also important in reducing cardiovascular disease. So that's why I give it 100%. So I wanted to qualify that answer in that context.
I'll jump in as the other cardiologist here, Joel Kahn. A slightly different answer and nothing but respect. I completely agree that the impact of lifestyle, nutrition, sleep, fitness, stress management is going to be like pack your smoking. For those of you that are listening, doctors ask you how much you smoke, pack a day, 40 years. We call that 40 pack years. I would say, do you have 10 lifestyle years where you've really focused, 20 lifestyle years, 30 lifestyle years? The earlier, the better, and the more impactful for preventing the disease And if done right, the more impactful for halting and potentially reversing a disease. I'm not as optimistic, though, that it's 100%. There was a research paper in January of 22 where they did a panel of 162 genetic tests in heart patients. And the paper said that they concluded, now let me say, I do 4 genetic tests in my patients, and they're expensive. Even lipoproteinase cholesterol is sort of a genetic test. That's not expensive. But if I want to draw something called apolipoprotein E, hugely important gene, it's expensive. I do 4. They did 162. Their conclusion was about 40% of cardiovascular disease was genetic, 60% was lifestyle. I think that's a little too high, but I don't think it's 0 and 100. I mean, I think you can do a lot of things right, and there's still some risk, but you can mitigate the majority of it. We're getting better, and I'm sure the cardiologist in 5 years, along with your blood sugar and your blood cholesterol, is going to have a genetic panel that's easy to interpret for the doctor and the patient. That's one of the biggest, drawbacks of 23andMe, is trying to figure out what the heck does all that mean. But anyways, earlier the better. But never wait. If you're 85, start. If you're 80, start. If you're 75, but if you can grab this as a child or a teenager or a young adult, that's superpower.
Yeah, one comment about the genetics I'll say is that you're right. There are a lot of genetic impact into heart disease, but let's take ApoE, and if you have the suballele 4, that predisposes you to a stroke and cardiovascular disease. But the genetics can be controlled by the environment. So really it's the epigenetics. So the way I look at genetic disorders, excuse me, is that let's say you have a blueprint to build a house. So your genetics is the blueprint for a disease. But if I have a blueprint, an architectural rendering of a house, I don't have a house. I have to hire a contractor, subcontractors, and express that blueprint into a real house. Similarly, if you have a genetic predisposition to heart disease or stroke, that's just the blueprint. But the epigenetics, the poor lifestyle, that's your contract and subcontract that expresses that genetic defect of heart disease into heart disease if you have the abnormal lifestyle. So if you don't have the abnormal lifestyle, you can still have the abnormal gene, but not manifest the disease states for which the gene is the blueprint for, if you cut off the disease at the epigenetics. And that's where lifestyle plays a big important role.
Agree. Yeah. All right.
Thank you.
I'll say from the GI perspective there, I'll say that every single thing that you mentioned, the first thing I talk to my patients about is diet and lifestyle. Almost all of those disease processes have to do with sort of some changes in sort of how much you're eating and what you're eating to control those symptoms, from the constipation. Everybody in this country is, very focused on, having protein. Protein is never our problem, but fiber certainly is. And so that's why so many of our patients have constipation, and that goes hand in hand with bloating, abdominal discomfort, nausea, feeling full very quickly, or early satiety. And also patients overeating, which we also see with elevated, patients coming in with so many symptoms of heartburn and that sort of thing. So yes, I think there are outliers. We do all of these fancy tests to look at how much acid a patient has, to do sort of pH impedance testing and Bravo test, and all of these tests to see if somebody has abnormal secretion of acid. But also the biggest thing is sort of how much people are eating, how much are we consuming. Does somebody have a hiatal hernia? Yes, but not everybody with a hiatal hernia will come in and sort of complain of sort of this terrible significant acid reflux. And so I think for a large portion of most of our GI patients, diet and lifestyle are going to be huge. Most people don't want to hear it necessarily. They want us to give them a medication. They want our endoscopy to magically fix those things. And so we have to tell them, yes, we can do it to make sure nothing else is happening. However, the likelihood of my endoscopy is going to fix your heartburn or your nausea is unlikely. There's one other thing you mentioned, inflammatory bowel disease. There have been studies that have shown that as countries sort of switch their diet to more westernized diets, they see a rise in sort of the number of patients that have inflammatory bowel disease. And so we also see that being associated sort of greatly with diet and sort of more processed foods, more fatty foods, more fast foods. And that's what we see as sort of being less fiber, less water, sort of in those patients having a change in their microbiome, which I'm sure Dr. Pasricha will talk to us a little bit more about. And we see those patients having less diversity in microbiome and therefore more GI disease. So I think diet is huge in most GI symptoms. We don't have typically a lot of time and a lot of GI practices to sort of delve into that with a lot of patients, which is why I started my practice. But I think it's huge in most of our patients.
Yeah, so and I kind of echo and agree with what everybody is saying here. If you think about it, the average American eats about 2,000 pounds of food in a year. And the average American diet consumes about 60% processed food, 25% animal products, very little fiber, fruits, vegetable, whole grains. So what we eat is most definitely going to affect our GI tract, our gut microbiome, and really every GI illness that I can think of is in some way, shape, or form linked to what we eat, our diet, and our lifestyle. Now, yes, is there a genetic component to certain things? Yes, we know there is a genetic component of inflammatory bowel disease. There are genetic risk factors with families who have colon cancer. But a lot of and same with celiac disease. So there is a genetic link for certain GI illnesses, but a lot of them, it's diet and lifestyle. You talk about reflux, irritable bowel syndrome, just having bloating, gas, constipation, diarrhea. Actually, I spent a year in the middle of medical school doing something called a Howard Hughes Medical Institute Fellowship. It's an NIH grant, and I worked in a basic science lab because I was trying to find the genetic component, and if there was a genetic component to fatty liver disease. That was my area of interest because for those of you who don't know, just like we get fat anywhere in our body, we also can get fat in our liver. And with time, it can result in scarring, inflammation, and cirrhosis, meaning the liver has failed. And in the United States, this is quickly growing, and it's becoming one of the fastest reasons that people in the United States need a liver transplant. And this is essentially a purely lifestyle issue. There is fat in the liver causing liver failure. We now know that. When I was doing my research, I was trying to see if there was any genetic component because we do see a lot of families come in and they have fatty liver, but I couldn't find any genetic component. And there really, even to this date, we've not found any gene that's linked to fatty liver. And that's really because probably like a lot of these other GI illnesses, it's a result of the food that we eat, what we are putting in our body, how it's affecting our gut microbiome. And so, all of these issues are definitely related to diet and lifestyle. So I emphasize and talk with my patients and counsel them on the right things to eat and kind of the right lifestyle for a lot of these GI illnesses.
Thank you. Just going back to what you said, Dr. Kahn, Caldwell Esselstyn is famous for saying heart attack proof. So aside from the research for you and Dr. Montgomery, what's happened in the last 15 years to all the whole food plant-based people you've seen? In other words, the people of the last 1,000 people that you've seen between the two of you, how many of them said, okay, I'm eating a whole food plant-based diet 15 years ago. What happened to them? Did they have heart disease? Did they have stroke? Did they have erectile dysfunction? Or they ate a great diet and lifestyle and they didn't get it? Like, forgetting about all the research, what's happening in the real world? Do regular people who follow your advice sometimes get heart attacks and strokes and erectile dysfunction or not?
Yeah, I'll answer and then we'll leave it for Dr. Montgomery. I am completely convinced that the most powerful recommendation is to change your diet to a diet without processed food that's either largely or completely colorful plants. I eat an only plant diet, but I also honor some research by Dr. Walter Longo at the University of Southern California and others that certainly get credit in the nutrition world. There are other lifestyle interventions like sleep, like stress management, like quitting smoking, like some fitness. And when you combine them all, it's powerful. I would not call it bulletproof as a guarantee. I've seen people doing it right and have that next event, even a cardiac arrest they had to be resuscitated from. Usually we can identify it. It's usually lipoprotein A. It's usually a gene called NP21. It's usually maybe some inflammation from a source we didn't realize, a hidden infection under a root canal that was driving their C-reactive protein up. So, I mean, I monitor blood work like crazy. And if you give me that person and their blood panel's benign, their high sensitivity troponin is low, their panel of inflammatory markers is within normal range, I'll give you a pretty long-term bet on that person. But if it's not that way, I'm digging, and I think I'll just give one last statement. A lot of plant-based eaters are very deficient in omega-3. They're trying to get their flax, their chia, their hemp, or they're not, or they can't convert it. And you can measure it. So I measure it in my plant-based eaters. I measure it in the others too. And I really educate. That's probably when I spend more time than, that would surprise people. Going over omega-3 source foods to cool down the inflammation using targeted nutrition.
Yeah, I agree with pretty much what Dr. Kahn is saying, because it's pretty tricky. So if you make the blanket statement that if you're on a whole food plant-based diet, you're bulletproof, you can miss a lot of people. I've seen a lot of people who come into my office and they fly in from all over the country and they say, well, I'm whole food plant-based, SOS, et cetera. And they'll have advanced cardiac disease, they'll have abnormal inflammatory markers and the like. One has to be very precise, and our approach is one. And when I use the phrase the food prescription, because not only do we look at the fact that I'm pretty sure that plant foods are superior to animal foods. I think the data supports that and the like. So then when you say within the context of eating plant foods, what foods are you eating? Because someone could be eating a whole food plant-based diet, quote unquote. But in my book, if they're microwaving their food, if they're sauteing, if they're overcooking things, if there are a lot of preservatives in it, et cetera, these foods may not be ideal. That's one. Two, it depends on what level of illness that person's in. We get patients with end-stage heart failure, with atrial fibrillation, who are in the ICU, managing patients with both liver dysfunction, renal dysfunction, kidney dysfunction. And so in these patients, it's not just a matter of a whole food plant-based diet. I put them on raw detox with time-restricted eating. We do intermittent fasting with time-restricted eating, sauna therapy. There are other therapeutic interventions that we have to give, targeted supplementation. We have to look at the omega 3 to 6 ratios, look at inflammatory markers. We look at lipoprotein a, we look at ultrasensitive troponin, et cetera. So for our patients who are at advanced heart disease, we do an integrative care approach. And I've got a patient with amyloid cardiomyopathy who has an ejection fraction of 20-25%. He's getting better. He's on a raw diet. When he was eating a whole food plant-based diet with some cooked foods, he had some problems. So we had to advance his diet more, plus add other things. And so you have to be very precise when you're dealing with patients with advanced disease. And yes, the diet matters, but you have to be very precise with the nutrition. And people with more advanced disease need a more advanced nutritional therapeutic intervention. So that's why we have our own nutrition center, our own restaurant, our own food preparation in our center, because we have to control the food. And I think in the world of medicine, we have to be very, very precise in how we use nutritional intervention. Just to say whole food plant-based and you're done is not enough. If you're starting from a normal individual in utero and eating natural whole food plant-based and it's from the garden, et cetera, that's going to make a big difference. But you've had experts on this very program talk about whole foods that are not necessarily whole foods. There may be GMO products, foods that are grown across the country and shipped and gassed and high. So these foods are not ideal. So many of the foods we get out of the supermarket, they may be in cans, they may be preserved in different ways. So we have to be very, very precise in the foods we prescribe our patients. And in our center, we use locally grown, sustainably grown, organically grown produce that we get to our patients in a minimally processed manner, especially our sicker patients. And I think that part has to be overemphasized. So if patients on a pristine plant-based diet with time-restricted eating, intermittent detoxing with some other interventions added, I agree with Dr. Kahn. We have to follow the biomarkers very closely, very carefully to see how their body's responding to this therapy. In that situation, those patients do well. But just to throw blanketly say your whole food plant-based, I'm not so certain about that. And I don't think we can apply a bulletproof guarantee to just that recommendation.
Thank you. What is irritable bowel syndrome? How do you get it? How do you treat it? And is this the #1 gastrointestinal issue? Like, is that a blanket term for a lot of different things? What is irritable bowel syndrome?
Sure, I can talk about this. So irritable bowel syndrome is basically a syndrome of different symptoms. So people usually have abdominal pain. It's chronic. It can be associated with a change in their bowel habits, either a change in the form or appearance. And it's often associated with defecation. Either they'll get improvement in their abdominal pain after they have a bowel movement, or they'll get worsening symptoms when they're having a bowel movement. This is based on something called the Rome 4 criteria discovered by Dr. Drossman. And irritable bowel syndrome is very, very common. It is the most common thing that gastroenterologists see in their GI practice, and I'm sure Dr. Laster would agree. It's also very commonly seen in primary care physicians. It's 1 out of 10 primary care doctors will see patients for IBS. So it's very common. And we think that it's related to gut bacteria abnormalities. In our GI tract, we have 500 trillion gut bacteria. We have good bacteria and bad bacteria. And when that bacteria becomes imbalanced, we get something called gut bacterial dysbiosis. And that can lead to something called gut bacterial permeability. What a lot of people in the lay population call leaky gut. And we can talk more about this, now or later if you want, but really we have a very thin layer of epithelial cells that separates what's in our GI tract and in our gut from what's in our blood. It's called the gut blood barrier. And it's really important that that thin layer stay intact. If that thin layer of epithelial cells becomes intact, either from an infection, harmful pathogens, harmful bacteria, then we can get a whole host of other medical issues, and IBS is thought to be one of those. We used to think that IBS was a psychiatric illness and a psychiatric issue because, the symptoms can be a little bit vague, and it can be really frustrating for patients because there's no one test that is going to diagnose IBS. It's not something that you can see a primary care doctor, you can see me as a gastroenterologist, and I can order a lab test, blood work. It's not going to happen. Nothing will come positive. Your blood work will be normal. Any imaging, CAT scan, ultrasound, it'll be normal. You might have a colonoscopy, upper endoscopy, that will also come back normal. So it's very frustrating for patients. And like I said, we used to think it was the psych issue. They were maybe making it up. We know that's not true at all. We know that there's a gut microbiome issue. We also know that there's something called visceral hypersensitivity. Patients actually experience more pain, heightened pain. They're feeling pain. There have been research studies looking at this. There have been studies where they put a rectal probe in people's bottoms, and there's a balloon at the end, and they'll fill the balloon up with saline and air, and they'll ask patients, healthy patients and patients with IBS, and they'll ask them, tell me when you're starting to experience pain and discomfort. And the studies have shown that patients with IBS consistently have pain and discomfort at an earlier point than healthy patients. So, we know that the pain is real and it's very frustrating for patients, but we think it's related to the gut microbiome, the foods that we eat, and also stress. I mean, we know there's a lot related: stress, alcohol, all of those things play a role. I mean, I actually gave like a 2-hour lecture on this today, so I could keep going on. I don't want to take the whole time, but one of the other things just to think about is with irritable bowel is, there is a brain gut connection. And so if we are stressed, anxious, and worried, that will most definitely affect our GI tract. So not an easy answer. I tried to summarize it briefly. Hopefully that helps.
I'm not sure if it's against the rule for panelists to ask another panelist a question. Do you read stool samples in your patient with IBS? Do you use stool samples in your practice?
So we do stool samples. I guess it depends what type of stool samples. So in patients who have, or I'm thinking about irritable bowel syndrome, and they're coming in with diarrhea, for example, I mean, it is important that I rule out other issues. I want to make sure I might check stool samples looking at inflammation. I might check stool samples just to make sure they don't have any infection. I might look to make sure they don't have pancreatic insufficiency causing diarrhea. So I do those type of stool studies. I do not do stool samples looking for, specific gut microbes, because really, I don't believe that the GI literature supports that at this time. I think that it's not validated yet. And I really don't know what to do if patients, they do these tests and they bring them in and they tell me that they're high in very specific strains and low in specific strains. And I don't know what to make of that right now. Because really, okay, I can see your gut microbiome is unhealthy. And I probably could have told you that without that stool test. And my treatment for a lot of those things is often diet, whole food, or plant-based, or having more fiber, and lifestyle changes, reducing stress. So I do not routinely check for gut bacterial strains.
But would there be a before and after change you would expect? To say someone had a bad looking stool and they got on a healthy diet, would you expect certain changes or not?
In the research, we are seeing that. We are seeing that patients who are on a plant-based diet versus an animal-based diet, there's gut microbiome differences. We are seeing people that when, if you take a stool sample before, like on a normal diet, and then they switch to a plant-based diet, we are seeing gut microbiome changes. And the answer to all of that, just to kind of key in, is that the gut microbiome does seem to improve when you're on a plant-based diet. And the gut microbiome, the harmful bacteria gets worse on an animal-based diet. The research studies show that when you're on a plant-based diet, we do see more diversity of bacterial strains. That's important. And we also see more of the healthy bacteria. So it's also important. So there are research trials on it. I think in the future, we will be doing those type of testing, but there's not enough for me to recommend. The GI guidelines do not recommend routine testing. So we're not there yet, but as more and more research comes, I think we will be able to identify which strains are going to be important. And then eventually, maybe we'll be able to target that a little bit more, but routinely we're not there now, and the GI guidelines don't recommend it.
I could not agree with her. I want to just send this and just put this up for all patients. I think the one piece that if people who are listening who have IBS or struggle with sort of GI symptoms is so many patients are so frustrated and they go to see so many gastroenterologists, and I'll have patients that I am number 17 and they're coming in sort of demanding another upper endoscopy, another colonoscopy. And they don't want to hear about sort of dietary changes and stress relief and sort of, mind-gut connections and these sort of things. And so it takes you a little bit of time to sort of create that bond so people can hear you as well, because they come in with their binders and they are ready sort of to go to war with us, right? But it's super important for patients to understand that we believe you, we hear you. You are 85% of what we see every single day. And it's really so much about sort of that mind-gut connection. And the one thing that she mentioned earlier that I absolutely love, and I go through sort of I nerd out with patients a little bit to get them to sort of understand this. There's data on a lot of this stuff, but that thin layer is super important. And there's been data that shows us that the more this is my, spiel to get them on my decreased processed food sort of train, is telling them that this leaky gut everybody sort of reads about. What we care about in GI is making sure that that lining stays intact and you don't have sort of that penetration there. And so what studies have shown us is that processed food does just that. Processed foods ruin, kind of change your diversity and their small bowel. Your small bowel goes, I don't know what to do with all of these emulsifiers and additives, and so therefore it's going to have more inflammation. You get more bloating, more abdominal discomfort, more food intolerances, which we also see a lot of, as patients will say, well, no, I can't eat a salad. I just can't eat fiber. I can't eat these things. And that's because we've created a microbiome in which your gut is unable to process those things. And so explaining to patients, I sort of explain it to them as like, we trying to garden here. And if you can't plant a garden with, Doritos and Mountain Dew, nothing's going to grow there. And trying to get patients to understand sort of from that perspective, what we mean by a whole food plant-based diet. And the other thing also I'm like, we all see the same patients clearly. They must come from DC and go to Delaware because they come in with these stool tests that they've gotten from some person, but they want us to interpret said stool test. And there is there's no guideline for that. We can tell you it's the same thing. When you come in, I know you have a disordered microbiome. You tell me what you're eating, we talk about your diet. I know that. I don't need those stool tests to tell me. And I know it's also going to change by us getting you on more fiber, more unprocessed foods, more whole grains, actually drinking some water. And so that's one key take home for anybody that's watching that has IBS is we do believe you. We know that it's real, and we're not trying to keep away some secret from you when we talk about sort of changing sort of diet, getting sleep, and sort of reducing stress, because it's all very real.
Thank you. Next two questions. Do whole food plant eaters need to get scans to check the health of their arteries? If so, which type of scans? And what % of the time are gastrointestinal issues anatomical as opposed to being from our lifestyle?
Baxter, you start.
I think it depends. Again, I think Joel and I, we agree that whole food plant-based label, quote unquote, is not a bulletproof guarantee. You have to get into the details. And it depends on your risk factors and other things. So for example, if a patient comes in and sees me and they say, well, I'm whole food plant-based. Okay, wonderful. Are you having any symptoms? No. And I look at their ultra-sensitive troponin, I look at the pulse score, I look at these things that have no vascular inflammation, they have a stress test that's normal, the ejection fraction is normal, et cetera. Blood pressure looks good. Lipids look good. So that person doesn't need a scan. That's a whole food plant-based patient. But another whole food plant-based patient comes in and says, well, I'm having, chest is pumping on a regular basis. They have an abnormal stress test. The inflammatory markers are abnormal. I'm going to ask them exactly what they're eating and start to modify what they're eating, even though they say it's whole food plant-based, because it probably needs to be some improvement there. I'm going to look at the vitamin D levels and other types of biomarkers to see what needs to be corrected there. But that person may need a scan depending on what the symptoms are. If their ejection fraction is compromised or lower than normal, then that person will need a scan. So I gave you examples of two extremes of people on whole food plant-based diet, one who wouldn't need a scan and one who would need a scan. So it all depends on their clinical scenario. Just because someone comes and says a whole food plant-based, I don't throw my, thinking cap away from a medical standpoint, because, some of those people need to be evaluated one way or the other. I'm still going to intervene nutritionally and lifestyle-wise, but that person may need a scan on the one hand versus the other may not.
And I have a little different approach, and that's always healthy and okay. But let me just define for the audience. You can either for free in Cleveland, and Dr. Montgomery, correct me, but if the Widowmaker movie is correct, at age 50, you can get a heart calcium CT scan covered by insurance in the state of Texas. Or in my state, pay $75 and literally in about 5 seconds, get a heart calcium CT scan. And you pay out of pocket in most states, and you will get a number from 0, relatively certain jubilation moment, but not 100% jubilation, just like whole food plant-based eating is jubilant, but not 100% jubilant. Or you get a number back that could be 100, 300, 600, 1200, the degree of calcification of your heart arteries, the degree of vascular aging. So I have probably 99% of the patients in my practice have had that scan, unless they've had a bypass, a stent, a heart attack. They know they got a disease. But if you're a new patient to see me, I'm going to talk to you that for under $100, or in some cities for $0, we can define beyond just lab work and history. And I take extensive histories and extensive labs, but come back 0, let's talk about that test in 10 years. Comes back high, I'll probably never do it again because I already got my information. There is now a more advanced CT scan called CT angiography. And the real exciting thing is it's now being read by artificial intelligence. And there's a company called Clearly Health. I'm not involved. There's a company called HeartFlow that's working on that. And the ability for a cardiologist like Dr. Montgomery and I to tell a patient, 80% of the plaque in your coronary arteries and how much volume it is, but it's soft, non-calcified. We can't pick it up on these calcium CT screening scans, but it might change your life one day with a heart attack or stroke, is extremely exciting. The trade-off is it's a little more radiation and involves contrast. It's more expensive for sure. So I'm selective with these artificial intelligence CT scans. I'm pretty broad. And again, I've been doing this for decades. I love every whole food plant-based eater. I don't assume that they can skip their mammogram, their colonoscopy, their digital rectal, or what I feel is just the comparable equivalent, the heart coronary calcium CT scan. But I use it very rarely, and I very often never repeat an abnormal coronary calcium scan. I just know I got to work on this patient more.
Thank you.
From a GI perspective, when we ask what percentage of GI symptoms are anatomical, a couple come to mind, such as a hiatal hernia for heartburn, sometimes bloating when someone has they can have diverticula in the small bowel, or somebody has had an surgical anatomical change, like a gastric bypass. They can have SIBO, or from those, let's see. And those are, or if somebody had something done surgically, they can have certain things, certain types of diarrhea, sometimes diarrhea after, you have your gallbladder removed. I'm trying to think of other reasons why, other anatomical reasons for people to have GI symptoms, but those are sort of the common ones that come to my mind. Can you kind of think of any more, Dr. Pasricha? Those are the big ones that would cause you to have sort of GI symptoms. But I also think, in addition to sort of you having something anatomical, it is still dietary in a lot of ways to sort of change those things. Sometimes I'll have a patient that is on a perfect diet, that is not have excess weight, that has been on not only a perfect diet, not only smaller meals, not only avoiding trigger foods, on a PPI, and they still have, terrible heartburn. They still have terrible elevated levels of acidity when we do a pH impedance study. And these people maybe would need to have sort of a surgery called disinfundiplication, or sometimes it could be done endoscopically now to treat their hiatal hernia as a cause of their acid reflux. So just like Dr. Kahn and Dr. Montgomery said, there are instances in which a patient can be on this sort of perfect diet and still have some symptoms. I don't think it's extremely common that I have a patient that is sort of normal, normal weight and on a perfect diet and sort of continues to have symptoms with a hernia, but it can happen.
Thank you.
Yeah, I agree with you, Dr. Laster, that most of the GI illnesses and conditions I see are probably lifestyle related. You mentioned the main ones that are anatomic, the hernias, the scarring and narrowing, usually from a surgery, some stenosis of some sort. But most of the time it's from some sort of lifestyle issue that's going on. But I agree that, when people are coming in with symptoms like abdominal pain or, change in bowel habits, like we still need to do the workup to make sure, because even though things like a blockage or a cancer, these type of things are very rare, we still need to make sure that it's not that, so we can treat it appropriately and not let something go missing for a long period. So if somebody is coming in with a lot of upper abdominal pain, we kind of need to look, is there an ulcer? Is there a bacterial infection? Is there an anatomic blockage or hiatal hernia? So, you know, we don't know until we do the workup. We are lucky that we can do endoscopies and we can actually see inside. So it is important that, you know, patients take advantage of the tools that we do have to look and see what's going on. Once we make sure there's nothing else, then we can always focus on making lifestyle dietary changes.
And I just want to add one comment, because I think there's a common thread to the questions about specialties, and I mean, we all agree that, you know, everybody who proclaims a perfect diet, you know, needs to have an evaluation, and it's not, at least for myself, and maybe my panelists feel the same way. I don't think the perfect diet is not perfect. I think the proclamation of a perfect diet is not perfect. So people come in saying, I'm on a whole food plant-based diet. And then you start talking as well. I eat, you know, fried chicken every, you know, third Sunday or something. I don't know, you know, it's, you know, so people will give themselves a label that I'm eating a whole food plant-based diet, or I'm eating the perfect diet or whatever. But, you know, that's a proclamation of a perfect diet. It's not by evidence of perfect diet. So, it's tricky in our area when we're trying to straddle both lines, practice sort of on a natural, holistic, you know, lifestyle fashion, and also do the traditional medical things. Because if someone says I'm on a perfect diet, and you say, okay, great, you don't need a workup, and they have a cardiac arrest, then, you know, it's a problem, or they have some massive GI problem, it's a problem. So that's the tricky part in this. So I want the audience to understand that it's not, at least for me, I'm not saying an ideal diet is not ideal, but when someone comes in and say I'm on the ideal diet, I need to examine that more carefully. And if they're having symptoms that contradicts that they're on an ideal diet, then I need to evaluate that, because I'm responsible for that.
Agreed. Just because you're on an ideal diet doesn't mean you don't. I'll have patients that say, well, I don't need to have a colonoscopy because I don't eat meat and I have no family history. Yes, you still need a colonoscopy. That's the gold standard for testing for colon, to check for colon cancer. And we can remove polyps before they become a cancer. So not eating meat, that's great. I don't want you to eat meat, because the opposite of that is I'd take out 8 polyps from a patient. As soon as they wake up, the common question is, oh my God, what do I need to do to make this not happen again? And as soon as I say reduce, processed meat and red meat, everybody goes, okay, everything but that. So that you still need a colonoscopy, even if you don't eat bacon and sausage and steak every day of your life.
Thank you. During this conference and in previous conference, there's a nutrition discussion or debate that seems to happen, which is a lot of speakers recommend eating a whole food plant-based diet. And there's a large number that recommend eating beans, whole grains, seeds, nuts, fruits, and vegetables. But they are not very, they're definitely against oil, and they kind of want to minimize nuts and seeds and olives and avocados. So they're basically, even whole foods, plant fat, they're saying to minimize, and oil completely, don't have it all. Then there's another group that says, no, fat is actually good. You want nuts and seeds, you want avocados and olives, and oil is okay. So where do you stand on avocados, olives, nuts, and seeds as one category of plant fat, and then a second category of oils like hemp, flax, and olive? Are these things that are part of the diet? Are these things that are not part of the diet? Please help us share what you think about this. All 4 of you.
I'll jump in and take avocados, and I'll leave all those other food choices to the others. We can circle back. You know, just depending when you're listening and watching this, but if you're watching it live, just within the last 10 days, the Harvard School of Public Health published an analysis. Believe it or not, it's amazing. But in 1982, they started the Physicians' Health Study and the Nurses' Study, involving over 100,000 medical professionals who agreed to fill out insanely long health and food questionnaires every 4 years. And they followed that group up for 32 years. during which about a third of them died, and some had heart attacks, strokes, and other events. So they can analyze what's the impact of anything in the database and do the multivariate analysis. So they looked at avocados in a publication presented to the American Heart Association. And what they identified is when you factored in blood pressure, smoking, diabetes, obesity, all the things you have to do to isolate a single nutrient, that eating 2 half avocados a week reduced the risk of having a heart event over 32 years by approximately 20%. And they couldn't find anything negative about it. And we do know avocados are richer in fiber than most people give credit to. They're very rich in plant-based nutrients, chlorophyll, and the rest. They do have a small amount of saturated fat, nothing like butter or lard or coconut oil or palm oil. But it appears, at least in these big studies, not to impact, ultimately the most important measure, lifespan and early coronary death. There are other studies about avocados having a beneficial effect on endothelial function and cholesterol. So they were excluded from those famous studies, Dr. Ornish, Dr. Esselstyn, Mr. Pritikin, even Lester Morrison in Los Angeles 50, 60, 70 years ago. So there's been relatively little actual heart disease reversal data on avocados. That's why the Harvard School of Public Health data is important. And I vote yes, but stick to the study, 2 half avocados a week, and always check with your doctor and your nutritionist first.
I'll do a quick screen share.
Sure.
I'm going to agree with my colleague, Dr. Kahn, on the avocados. Here's a study. Let me just kind of show you the study. We looked at the defined plant-based diet in clinical patients in the approach in 4 weeks. We showed a reduction in lipoprotein(a). We're actually the first in medical literature to show that by 16% in just 4 weeks. And other inflammatory atherogenic lipoproteins were reduced. And just quickly regarding the foods they ate, I'm not going to go through this whole list, but if you look at the avocados here, and again, this is not really a fair assessment, but they went up by 800%. It was a nine-fold increase in the consumption of avocados in 4 weeks in this population. Now, they reduced animal proteins and got rid of a lot of bad things, so you can't just say it was an increase in avocados. But the reason I just point this out is that, at least in this study, in our center, in the acute, and this is a group of patients with hypertension, hyperlipidemia, their body mass index was about 34, 35 on average, and they were pre-diabetic, average hemoglobin A1C. We saw a reduction in hemoglobin A1C, reduction C-reactive protein by 30%, reduction lipoprotein(a) by 16% in just 4 weeks. And so that increase in consumption of avocados. Now, the amount of fat they had in this diet was right at 20%. So it was not what you call that so-called 10% or super low fat diet. It was a 20% fat diet. But what we emphasize is that all the fats be raw. So to answer your question directly, I would say yes to the whole fat foods, avocados, whole seeds. Most nuts have a favor for pistachios and walnuts, and seeds such as pumpkin seeds, but yes, and even olives if they're not overly processed. I say no to the oils because extracted oils can be problematic, even if it's the first cold pressed oil. You don't know how it's extracted. If it's truly extracted first cold press, but then it sits on the shelf, it becomes rancid. And then the oil itself is missing a lot of ingredients, a lot of fiber and other things. So the whole food, the fat from the whole food is important. My emphasis is that the high fat content foods must be raw. They must be minimally processed, in my opinion. So that goes to the avocados. Don't roast them, don't steam them. Eat them, fresh, raw on your salads. Same with your olives, same with your seeds, nuts, etc.
Thank you.
I didn't know if our gastroenterologists want to grab any of the foods. I'll just say, again, trying to keep it in the science world because we're all academic trained docs. The Gates Foundation, I think that's what you call it now. You don't name the couple anymore. The Gates Foundation has that study called the Global Burden of Disease, 190 countries, 3,000 investigators, and tens of millions of people tracked for their nutrition and their outcome. And they reported about 4 weeks ago, the 3 top foods for longevity in this massive nutrition database. Number 1 was beans, number 2 was nuts, and number 3 was whole grains. So it kind of blows away the plant paradox, killer lectin, whole grain as a uniform, harmful group. It certainly questions some hesitation about eating nuts that has occurred in certain heart disease reversal diets. And I agree with Dr. Montgomery. Walnuts for their omega-3 fiber, endothelial function. Pistachios really support nitric oxide production. So they're kind of a super Viagra and pretty fun to eat. In the meantime, just don't eat the whole bag. And beans were number 1. And that's not the first time beans have been identified as the top longevity food. It's sort of the blue zones example, but actual academic research says yes to those things too. In the same global burden of disease study, all meat and processed meat were at the bottom of the list for the 2 foods most associated with shortened lifespan. So it's consistent with pretty much everything we're saying.
Thank you.
Yeah, I agree with you. I mean, I think it's fine to eat avocados, nuts, seeds. I am not aware of any GI literature that suggests that it is harmful to the gut microbiome. All the research that I have seen shows that it is supportive to the gut microbiome. I also probably deal with like a little, maybe similar population, but to try to talk to my patients about whole food plant-based diet, this is a new concept for a lot of my patients. And so, when we know that stress also negatively impacts the gut microbiome, it's really tough for me to get my patients on board on like a super restrictive diet. So I really try to encourage them that on a plant-based diet, on a high fiber diet, I want you to have variety of foods and I want you to eat different ones. And so I do include whole grains, fruits, vegetables, seeds, nuts, avocado. I feel like the research supports that. And if they start getting very stressed out or they feel like it's restrictive, I also let them know that's harming their gut microbiome. So really it's kind of a balance to make sure that you're eating healthy, but that this diet and this change is a lifestyle. It should not be causing you excessive stress. You should not feel extremely restrictive because then you're almost just doing yourself harm that way. So I think I haven't seen any research, like I said, to show that it's harmful to the gut microbiome. So I encourage my patients to eat those.
Is seeds and diverticulitis real?
I was just going to say that. That's why I was unmuting. That is so funny.
Okay. Oh,
that was a huge thing that we see a lot because people were told not to eat popcorn, nuts, or strawberries or diverticulitis. And I tell patients all the time, no, I want you to have all of these things. The data that's been debunked, there's no data that tells us that puts you at a greater risk for diverticulitis or episodes of diverticular bleeding. They are frustrating diseases because we don't have a thing to make people not have those events, but those are not things that we know that cause them. So yes, I tell my patients the same as sort of everybody on the panel here is to have your healthy fats via avocado and nuts. Because my space is very much an obesity space, I tell patients not to go overboard. So please not to eat an entire, bag of almonds or while you're sitting and replace that with your chips with a bag of almonds. So we talk about portion control a lot. And another thing I think in GI space as well, as Dr. Pasricha said, is trying to get patients to sort of understand this as a lifestyle change and sort of slowly taking them on their journey. If I tell everybody that came in, they had to be plant-based, they can't eat oil, everything had to be raw, they'd all go running like with hair on fire. So it's sort of slowly getting them there. And the fun part is we start to get them on board, their microbiome actually starts to change. So they start to crave those things that I want them to eat. And they go, man, I don't want soda anymore. This is strange. I know what's happening. Your microbiome is changing. You're changing things that you crave. And so I know I'm going to sneakily be able to get them there till they get to a point when they start to see those weight loss and changes that they want to stick with it. So at least I kind of have to start where we can and sort of slowly grade my way up when we get people talking about switching how much oil and oil in general. So, but agree with everybody else of keeping patients. Avocado oils, flax, chia, I love them all.
Thank you. Dr. Laster, please explain why you offer endoscopic weight loss procedures instead of bariatric surgical techniques. What is the difference between the two, and when is this procedure necessary? And then, and you can also, Dr. Bashir, comment on that. And then for the cardiologists, what heart procedures do you recommend and which do you not? How about stents, bypass surgery? How about bariatric surgery? Well, bariatric surgery is for weight loss. So how about stents and bypass surgery? So those are the two questions. First, the gastroenterologists.
All right, the fun one. So first, for the patients that are on, let me tell you what that means. So first of all, most people know about a gastric bypass or a gastric sleeve, which are surgical options for weight loss. The new kid on the block, and it's not really new so much anymore over the last maybe 20 years, has been sort of an endoscopic approach. And the way I explain it to patients actually is with cardiology techniques. I say, sometimes you don't need to go as far as having a CABG. You can have a PCI intervention with stents placed. And that's sort of how we think about endoscopic approaches to weight loss. The reason they came about is because we know that, at this point, 43% of our population is diagnosed with obesity or severe obesity. But these patients are candidates for bariatric surgery to help with weight management. However, 2% of those patients actually undergo those procedures. So we have this catch-all of patients that still need help with weight loss and weight management. And that's where those endoscopic techniques came in. And so what they are is done by endoscopy. So through a scope through your mouth, meaning patients wake up they go home the same day, no incisions. And it's sort of an in-between to help patients with weight loss in the background of changing patients' lifestyle, teaching them nutrition education, teaching them about portion sizes, and sort of getting sort of that mind on board to sort of be able to sustain those lifestyle changes. And so that's what those procedures are, either a gastric balloon or an endoscopic sleeve. There's also a device called the Aspire Assist. Also, new devices coming out all the time. One is called the Pose device that's not sort of FDA approved yet, but used a lot abroad. And so there are a lot of techniques that can be used to help patients with weight loss. And so how do I sort of approach weight loss with my patients? Because most of my patients that come in a lot of my patients will say, I've been doing everything. I've had sort of reduced my caloric intake. I exercise 5 to 6 days a week. These are all things that I've tried. And so we know, like Dr. Baxter talked about earlier, there's a lot of epigenetics that sort of play a role with sort of weight in a lot of our patients and sort of helping patients get over that hump and to get them there. Most of it is me changing sort of that diet that they already sort of have proclaimed as being super healthy and perfect. So changing those dietary things, but also patients get to a plateau. There's a bunch of theories about set point theory, about changing in the science that we've seen changes in basal metabolic rate once patients sort of have lost the weight. We know that reduces. Studies have shown us that ghrelin levels increase with weight loss. And so trying to be able to approach those patients that sort of really need help in those areas, but do not want to go as far as a surgical intervention. And so my approach is that, if somebody comes in with, a blood pressure of 180 over 110, you're not going to send them out and say, hey, you should really do that DASH diet and change your lifestyle, right? You're probably going to want to prevent them from having a stroke, so you're probably going to put them on some medication. And so my approach is sort of getting patients to that point where they're able to sort of start to see success and see some changes, because then the mind starts to get engaged as well. And then patients can buy into what you're telling them once they start to see that success. And they say, oh, I want to keep doing this thing. This actually works. I've started to change their microbiome and their processing and how they sort of approach food and life. And now they're ready to keep going. I have patients that have had a balloon and had that balloon removed. They continue to lose weight because now they like it. Now they have energy. Now they're sleeping better. Now their joints don't hurt when they go out with their kids. Now their skin is clear, which is all my ladies care about. Their hair is not falling out anymore. People are commenting, they're feeling better, they're having more self-confidence. And so these are things that keep that also enrich that microbiome as well, because you're feeling better. You're not having symptoms of bloating and abdominal discomfort anymore. And so you want to keep it. And I get people to sort of be able to listen to their bodies more, because now you recognize that when you go out and you have the meal that is, full of cheese and processed food, you notice that you are bloated and you go, oh, wow, that made me constipated. I paid for that thing for, I had a meal on Wednesday and I continued to feel symptoms until Monday. Maybe that wasn't worth it. And so getting patients to sort of slowly listen to their bodies. And so I think the other part of that question was at what point do I do those procedures? And every patient is very different. Some patients I will come in saying they really want to do those. And I think, I don't think you need that. I think we could really start talking about some of these dietary changes. I think you're on the cusp. I think you're almost there. And so I don't think you need that. If we have a patient that wants to have, maybe an 120-pound weight loss, maybe they've already lost 50 and they need to still continue to get to that point, and they have pre-diabetes, high blood pressure, fatty liver, and they really need to get out of that rut, I think that patient may be a good candidate, or if not, especially if they don't want to go for bariatric surgery. So the short answer of it is there are sort of great techniques that are low complication risk, no hospital stay, no incisions, very low minimum downtime, and sort of the new-ish kid on the block with few of us in the US that are performing them.
Thank you.
I have nothing to add to that. Dr. Laster is the expert in that field and she covered it just perfectly. So I just echo what she said.
Thank you.
Cardiac procedures, I'm sure what Dr. Montgomery does. I do a lot of second opinion. I had doc, my local guy told me I need a stent to bypass. What I teach them is just, and I think your audience should know, there's two major studies that do not apply to everybody. But in 2007, a randomized study called the COURAGE trial took courageous patients and courageous doctors in the VA with very bad chest pain and bad stress tests. And after they cooled them down, some went home on medication alone, and some got a balloon stent or bypass within 30 days. And in 2007, it was published there was no significant advantage to rushing to open heart surgery or balloon angioplasty stents in a group that mimicked, the patients in that study. That would have put 50% of cardiology out of work. So there was backlash and criticism and old-fashioned equipment. So that whole study was repeated, much larger, much better, and published in April 2020 called the ischemia trial, 5,100 in the world. And when the results were shown, rushing to a stent or bypass or going home on optimal medical therapy, a low saturated fat diet, and exercise proved to be of equivalent safety over about 3 years. Now, there's definitely people who shouldn't do it, people in a coronary care unit, people in the emergency room unstable. But if somebody's well enough to come see me as an outpatient, my education to them is you need to read this data and see if you're courageous enough to change your diet, take the medications, do your fitness, go to cardiac rehab, maybe an Ornish or a Pritikin cardiac rehab where they get that extra lifestyle training. And usually it's the first time they've been told that. So it's not a popular viewpoint, but I think it's the most ethical, science-based viewpoint. And I'll be honest, most of them don't do it. They buckle, and the local physician wins the day for good or bad. But for those who want to pursue it, those are the miracle stories that we hear, in documentaries like Forks Over Knives and What the Health, and they're very real testimonials. I mean, people can live for decades without those procedures, even though the majority of their care team said to have them done.
You're muted, Dr. Montgomery.
I agree with the comments of my colleague that typically patients who are in acute coronary syndrome, who are in the throes of a heart attack, or who are having a heart attack, are patients that I recommend that they would undergo an emergent procedure. Now, having said that, in my presentation night before last, I presented 3 patients who were acutely ill. One who was a 79-year-old man who was having a heart attack. He was cathed emergently by an interventional cardiologist at an outside hospital remote from where I practice. And he was found to have multivessel disease, including the infarct-related disease. And that interventional cardiologist didn't feel that he was a candidate for intervention, but felt he was needed emergent bypass. So he was going to refer him to another hospital, which I didn't go to, for emergent bypass. The family reached out to me through my answering service, and we brought him to our institution. I looked at him along with my surgeon, and we felt that we should wait for about 3 weeks. He had other comorbidities, and we put him on IV heparin. The patient went home against medical advice, came back in worse condition. So he was deemed too sick to operate on by the surgeon and not a candidate for PCI. So here's someone who was acutely ill in the ICU with acute cardiac syndrome. And so he wasn't, a candidate for theoretically the most aggressive therapy. So what did I do? I put him on a nutritional detox in the hospital. So we detoxed. And in my talk, I talked about how nutrition, the right type of nutrition in the right setting, can reduce inflammation and reduce oxidative stress very carefully. Some of the data I shared with you show that. I'm just going to show you another picture here of a patient that I saw in my office, a 46-year-old lady who came in with angina, and she had an ejection fraction of 24%. She was overweight. She went to initially see a gastric bypass surgeon to get a gastric bypass. However, they saw an abnormal EKG and told her she needed a cardiac evaluation. She came and saw us. I was concerned about the symptoms of chest discomfort. And like everyone, we started on a nutritional detox regimen, et cetera, which she had started, but I took it to the cath lab. And this is what we saw. Here's what you call a widowmaker. It's a proximal LAD lesion, about 90-95%. This was not in a good place to stent because plaque would go in the left main here. So we offered a single vessel bypass. She declined. She said, I want to try the diet. So she was more courageous than even I was and the rest of the team. So after 5.5 months on just diet alone, that lesion, which caused her symptoms, went away. And this is the large enlargement of the left main, LAD. And so ejection fraction went from 24% to 50%. So even though I typically say, yes, patients in acute coronary syndrome are the best candidates for either PCI or bypass, and I still say that, even in that situation, I think if they're getting those procedures, they need to be on an aggressive diet at the same time. And if they're not a candidate for those procedures because they're too sick to undergo those procedures, then they need to be on an aggressive nutritional diet. Nutrition, optimal nutrition, if applied right, works even in the most acute setting. And that includes patients on ventilators I've treated, et cetera. So while these procedures can be beneficial and life-threatening, remember when someone undergoes surgery, when the surgeon makes an incision and starts bovian and cauterizing, you're triggering increased inflammation. And so you may be trying to bypass a 90% lesion, et cetera, but you can have a 20% lesion with a vulnerable plaque that can rupture in the setting of an acute procedure, whether it's a PCI or bypass surgery, that can also put you in danger. And so that's why we did these studies that Dr. Klein talked about, particularly the COURAGE trial. When you compare, PCI to medication alone, it's not a free ticket to go get a angioplasty because you're only treating an isolated vessel or 1 or 2 isolated vessels, as opposed to treating the whole cardiovascular tree. And someone has disease somewhere, has disease pretty much everywhere. And the plaques that most likely will cause a heart attack are not the 80-90% lesions that were most likely to put a stent in or bypass, but they're frequently the 10%, 20%, 30, 40% lesions that were not likely to bypass or put a stent in. And many of those may have unstable plaque. And I've had a situation where I've taken patients in the throes of an acute myocardial infarction to the cath lab, put the catheter in, do the angiogram, and look at the coronaries, and I see nothing. And what happened is that that's a patient had a 20% lesion or 10% lesion that's not angiographically significant, that ruptured, thrombosed, caused a heart attack. And by the time I look at it, the thrombus has been lysed by the endogenous thrombolytic system. So while there are indications for these procedures, I agree with Dr. Kahn, they're emergent situations. Even in that setting, nutrition must be applied as an adjunct, and if the patient's too sick for surgery or angioplasty, must be the leading therapy of choice.
Thank you. Okay, I'm going to ask each of you a question. Feel free to comment on questions that are directed at someone else. Dr. Pasricha, what foods feed the good bacteria in our gut? How do we make the bacteria in our guts better? Dr. Laster, what are pelvic floor disorders and how common are they? And what do women do to avoid pelvic floor disorders? Dr. Montgomery, are we trying to avoid salt? Is this implicated in heart disease? And Dr. Kahn, you wrote an article called Why Your Cholesterol Does Matter, Ignore Nonsense Claims. Please explain that.
Okay, great. So your question was what foods or what feeds the bacteria in our GI tract? So, well, what feeds us is going to feed our gut bacteria. You know, we've all heard that expression, you are what you eat, but it's not just you are what you eat, you are now what your gut microbiome is eating. And at this point, we have numerous articles, numerous research studies that show us that if you eat a variety of fruits and vegetables, that's really the best thing you can do to feed your gut microbiome. The initial research came from Rob Knight, and they did the American Gut Project. What they did was they looked at American like citizen scientists. So they studied the gut microbiome in people like you, me, just nationally across the country, living their daily lives. And they did analysis to see what's the gut microbiome looking like in those patients. And then they did analysis to see which patients and why is it that certain people have a healthier gut microbiome than others. And really what they found was that those people who eat a variety of fruits and vegetables, those are the ones that are going to have the healthiest gut microbiome. And in this research study, they actually kind of quantified it. They found this number 30, that if you can eat more than 30 different fruits and vegetables in a week, you will have the most robust, healthiest gut microbiome. Now, I don't think there's anything special about the number 30. I think that's just to kind of give us an idea. If you're somebody who eats 28 or 33, like, I don't think you need to be stressed about that. And I think the basic concept is that the more different types of fruits and vegetables that you eat, the lower the processed food, the lower the alcohol, the refined sugars, that's what's going to get your gut microbiome to be the healthiest. So, you know, what you eat is really feeding your gut microbiome. We used to think that the gut microbiome was static, that it was in our GI tract and did not do much. We now know that is not true. Our gut microbiome is active. It is involved in hormones, in our immune system. So it does play a really vital role. And the best thing we can do is to minimize animal products and to focus as much as we can on different fruits and vegetables.
Thank you.
And all right, the question I think that was directed to me was pelvic floor disorders. And pelvic floor disorders can affect your urinary tract, so your bladder, your urethra, your rectum, your intestines, and what the pelvic floor is a group of muscles that sort of are able to sort of hold that, sort of to protect that floor of organs. So patients will routinely sort of present with urinary symptoms like urinary incontinence or urinary leakage. They can present with prolapse, whether that be rectal prolapse or uterine prolapse. Patients can also, what we see mostly is fecal incontinence, and sometimes we can see prolapse, rectal prolapse as well. And so we have a lot of fancy tests in GI as well to sort of test these things. And one of them I warned my patients about a little bit. Is probably not the most exciting thing that you ever want to go through, but an anal manometry where we're able to sort of test those muscles in that area with anal explosion of a balloon. And so what the most common thing is, and my patients will sort of get sick of me talking about it, to help with sort of fecal incontinence and to help with sort of colonic transit, sort of to help with those symptoms, are sort of dietary changes with fiber. Yes, and sometimes sending patients to sort of therapy to be able to have pelvic floor exercises to help sort of strengthen those muscles as well. Sometimes women will see it as we get older, women after sort of childbirth of very large babies, or sometimes that they've had to use particular types of forceps during any type of obstetrics procedure. Sometimes patients who may have had surgery or some type of nerve damage to that area as well. So there are many reasons why people will have pelvic floor disorders, and sometimes there are surgical approaches if patients are a candidate to be able to repair those areas. And a lot from the GI perspective for the fecal incontinence, if somebody has pelvic floor disorders or fecal incontinence, are sort of, first we try to do things sort of without surgery, without people having to undergo any procedures. So trying to change sort of their intake, getting patients to have more water, getting more fiber, trying to sort of be able to bulk that stool so you're not having that loose sort of incontinence. So you'll be able to have that sensation with more sort of stimulation throughout the colonic tract so that you feel it and you're able to sort of be able to hold that, so stool isn't so loose, so you're able to control it and to sort of pass stools without having accidents or episodes of incontinence. So that's the sort of the skinny pelvic floor disorders and sort of how they relate to GI disease.
I'll jump in if that's okay for just one moment. I actually did motility training, so I specialize, my area is pelvic floor disorders, and I do a lot of anorectal manometry. So just one or two things to add is that, you know, a lot of our patients will come to us complaining of constipation. And yes, the first thing is we do counsel them on diet. But even after eating a high fiber diet, they'll say, you know, I'm eating 50 grams, 100 grams fiber, I'm still bloated, I'm not going. So if you have that feeling of incomplete evacuation, if you are not emptying all the way, if you're pushing or you're straining, it really could be a pelvic floor issue and a rectal muscle issue. Those muscles need to relax when they're supposed to relax, tighten when they're supposed to tighten, and work when they're supposed to work. And for many people, it becomes discoordinated. We don't always know why that happens. You know, part of it is one that a lot of people, when they have to use a bathroom and poop, they're going to hold it in. They might not want to use it in a public restroom. We're seeing this a lot in younger people too, because they might not want to have a bowel movement at school. So they hold it, and they're starting to train their bodies to not go and to not listen to their bodies when they need to have a bowel movement, and that can affect those muscles. About 50% of patients who have slow colon and just like their colon moves slowly and causing constipation, half of those will also have a pelvic floor issue. So you really can have both. And one way we manage it is with the fiber and getting things to move, but the other way is, yes, pelvic floor physical therapy. The other reason that we are seeing a lot of pelvic floor issues is because we don't poop the right way. Like, as bluntly as I can say it, you know, kids, if you look at them, they'll often squat. In many other countries, when they have a bowel movement, they are squatting. And that's really the right way anatomically for us to have a bowel movement. But, you know, we all use Western toilets. And when we do that, it changes just the anatomy just a little bit and makes it more challenging to have a bowel movement. So many of these patients also benefit from using a small step stool, maybe the size, you might have it at home. If you put your feet on it, it changes the anatomy a little bit. You know, there's a company, Squatty Potty, I'm not affiliated, but they've done a great job marketing. And that's exactly what this is for. I do recommend patients who have constipation. It's a great thing to try, and it helps many of them, is just raise your legs a little bit. It changes the position and it can help with your constipation. So, you know, there have been a lot of research studies showing that people who have constipation, people who have fecal incontinence, they do not seek help because they don't think there is a way to fix it. And there's a stigma against it. So the only last point I'll make is that if you have those symptoms, please talk to your doctor, talk to your gastroenterologist, because there are definitely ways that we can help you and we can fix this. And we don't always do a good job asking about these things. So don't feel embarrassed to talk to us, because we really can get you to feel better, because these things significantly affect people's quality of life. You know, they have to wear pads or diapers, they can't leave the house, they get bloated because of the constipation. So there is help. So please talk to your doctors and see.
Thank you.
My question was, does cholesterol matter? Why did I write an article? Only to say that 98% of the cardiology world would ask, why is that a question? But there's a noisy 2% that question the role and actually encourage people to have a high cholesterol for the brain and their hormones and the like. There's a new book out in the last few months called The Clot Thickens, that's rehashed of other books that have questioned it. When you talk, academic medicine and science, one of the better groups is called the European Atherosclerosis Society or the European Cholesterol Society. And the premier paper they have out a couple of years ago is that LDL cholesterol is causative. It's the cause of clogged arteries. The only confusing part about it is that there are people with high cholesterol that don't get clogged arteries, and there's people with low cholesterol that do. It's a risk factor. It's not the only risk factor. Certainly, if you stack risk factors, high LDL cholesterol plus smoking, plus glucose intolerance, plus inactive life, plus high blood pressure, you're certainly going to multiply it. But it would be unwise to walk through life with a cholesterol of 280 or 330 and not at least get that simple heart CT scan or some other parameters to see how it's all working out for you. You might be the exception, but you might be the next statistic. So LDL cholesterol causes atherosclerosis. The kind of lifestyle approach to rectifying issues can be dramatic in lowering LDL cholesterol without medication, or if we need, we have this enormous choice of cholesterol lowering medications now we didn't have even 5 years ago.
Thank you.
Yeah, my question regarding salt, the main comment I make about salt is that our diet is so laden with added processed salt that, lots of people, have, it's sort of like the sugar issue in the sense that, if you were in this perfect world and you had only naturally occurring foods and minerals and nutrients in their natural environment, then we wouldn't have the problem. And so, but we don't live in that world. So things like sugar are not in their natural form, and we don't consume them in the natural ways with non-hybridized or GMO fruits, et cetera. We consume them in processed forms or manufactured forms. And similarly with salt, the vast majority of salt that people consume has been heated up to 2,000 degrees, it's added talc to it, et cetera. So many of the salts we consume are natural. So we're bathed in this unnatural salt. So from birth on up to adulthood, we have this whole biochemical milieu that's been contaminated by salt. So the vast majority of salt is overly processed salt. Now, you look at our blood, it's, sodium chloride is kind of the main nutrient. So to say that we need absolutely no salt would be too much of an extreme. And they've done studies where some of the recommendations of these very, very low salt diet recommendations have gone too far. The point I raise is to make to patients is to have them eat foods, natural food in a natural state. Plant foods, herbs. There's some food, celery has sodium in it. Sea vegetables has sodium chloride. So there's some plant foods that have naturally occurring sodium and salt-like materials. So if you consume foods that's minimally processed as close to its natural state as possible, I think that you're going to be in the best shape possible. But I want to emphasize the natural aspect of things. The other part is that when people look at, foods and it's processed foods, and it says, okay, low sodium, but there are many other preservatives in these foods. And so salt is not the only culprit. There are many dyes and chemical preservatives that are also bad for your arteries and your microbiome. So, even though, yes, salt is a problem, you don't want to add salt to your diet. You want to eat whole natural foods, use lots of herbs and seasoning in the natural state. But you don't want to just be so, focused on salt where you ignore other toxic substances, preservatives and the like that can also be harmful. And just a quick word on cholesterol. I agree that a high cholesterol is strongly associated with atherosclerotic coronary disease, but high cholesterol is associated with other diseases too. In Colin Campbell's study in the China study, high cholesterol is associated with cancer. So I look at high cholesterol not only as a causative agent of atherosclerosis, but I look at it as a metabolic disorder. It's a process in which the liver is not functioning normally. If your liver is not metabolizing cholesterol normally, whether it's too much or too little or whatever, then that's an underlying metabolic process that needs to be corrected. And yes, you can be predisposed to atherosclerosis with a high LDL, but as Dr. Kahn pointed out, you can have a normal LDL and have atherosclerosis too. So, disease states is multifactorial. And although we can find some strong associations in some blood tests and not strong associations in others, we need to look at the body as a whole and address it as a whole. And we don't want to just sort of look at one micronutrient or the other. But those are my comments on salt and cholesterol.
Thank you. Okay, I have 4 questions. You can answer whichever one you would like, or more than one. The first question is, do you recommend probiotics? And what about digestive enzymes? So that's basically, do you recommend probiotics? And what about digestive enzymes? That's really 2 questions there. Then the second question is, what about statins? Do you recommend statins for some people? Number 3, what about gluten? Should we eliminate gluten from our diet? And if someone has really sensitive stomachs, should they go further than gluten? Should they also eliminate quinoa and millet, even though they don't have gluten, just because some people say, I don't know what they say, but sometimes people say eliminate quinoa and millet also. I'm not sure exactly why. And then number 4, at this conference, everyone says to eat fruits and vegetables. And then Brian Clement from Hippocrates Health Institute says, look, he's been studying fruit for all these years under the microscope. It's feeding yeast, mold, fungus, sugar, candida, and cancers. And therefore, even though every single health person says eat fruits and vegetables, he's saying actually fruit you have to be careful with and shouldn't eat it that liberally, or got to be careful. So on those 4 things, if you could give us your thoughts.
Okay,
I guess
so
I'll start off. Oh, go ahead.
Oh, okay. Well, I can take the first question about probiotics and digestive enzymes. So the GI guidelines, GI Society does not recommend routine use of probiotics. I feel that with probiotics, we kind of take a swing and we go from one end to the other end. So there was a time period where I think a lot of us, and myself included, we were routinely giving probiotics for people. This is before we had a lot of research. And we did see that some of our patients were getting better on it. But the research has shown that there really is not significant improvement in patients when they take a probiotic. In fact, there's actually some research to suggest that probiotics can be harmful at times. Probiotics are not FDA approved. We're not sure exactly what's in it. We are learning so much about the gut microbiome at such a rapid rate, but we are still not at a point where we understand and know what strains of probiotics, the quantity of the gut microbes are needed. So, at this time, I don't recommend routine use of probiotics. If my patients are taking it and it's helpful, I think it's okay to continue. But if it's not helping, I think you're probably wasting your money on it. And instead, I focus on the prebiotics, which you can get in your vegetables, fruits, whole grains. So focusing more on the diet aspect. And in terms of digestive enzymes, this gets a lot of media press right now, but they're really, again, we don't have good guidelines to recommend routine use of digestive enzymes. Now, if you have pancreatic insufficiency, chronic pancreatitis, then we have ways to test to see if your pancreas is working. And if it's not working, then those are the patients that I would give pancreatic replacement. But I don't routinely give it, and the guidelines do not recommend routine use of these things.
Thank you.
What do you want to do, Baxter? You go.
Sure. Again, we have patients coming with GI problems. I've used probiotics and prebiotics and digestive enzymes, but I guess I'll stop tomorrow after this conference. The fruit issue, I think Brian Clements has a point, and I think it applies not only to fruits, but to all of our food. And we have to be mindful of where our food comes from. And so the answer to the question, do you allow the consumption of fruit? It really depends. And sometimes I will start a patient on a nutritional raw detox. And let's say they're diabetic and they have a sweet tooth, et cetera. And just because I'm restricting their diet in many ways, I will liberalize fruit at the beginning and then remove it not at the end, but later on. And then sometimes I'll remove it at the very beginning. But I think the fruit that we're exposed to, for instance, organic grapes without seeds, organic watermelon without seeds, I mean, these are very likely GMO fruits. And so, I haven't studied the biochemistry of it as much as Brian Clements has, but I think he has a point. And we do see clinical benefit when we make adjustments in patients' diet. Some people may have, systemic, fungus or whatever the case is, and so they may need to be off of fruits, on a low glycemic index fruits at the very least. So I'm mindful of the fruits, and I'm strategic in terms of how I prescribe them, and I'm mindful of the fact that fruits are often, many of the fruits are GMO, and I'll recommend organically grown berries and that are low glycemic index fruits. I recommend fruits that have their seeds in them when I do recommend them. Regarding statin drugs, again, it's only an as-needed basis. I've a lot of patients I take off statins, even if they have a history of coronary disease, if they're following the proper food prescription and if their biomarkers are coming down, et cetera. In our study, some of the data I showed you, we see cholesterol going down by 23% in just 4 weeks. We see Lp(a) going down by 16% in just 4 weeks, and even more over time. Statins, by the way, do not drop lipoprotein(a). And we see other parameters, inflammatory markers, going down as well. So we've been able to achieve in our approach the same thing or even greater with the reduction of statins. And there's some trials where the Jupiter trial in particular, where they saw an increase in the diagnosis of diabetes or insulin resistance in patients on statins for a long period of time. So yes, statins can be useful, especially if someone doesn't want to comply with an optimal nutritional diet. But I'm very strategic in how I prescribe these medications, as I am with the food. Gluten, we try to avoid gluten. Our nutrition center is completely gluten-free. Even though there's a small percentage of people with the formal diagnosis of Crohn's disease, we have a number of patients who just don't tolerate gluten for whatever reason. And I think it may have a lot to do with how our wheat is grown. I'm not sure, but we just try to avoid it. I'm not sure if anybody's died of gluten deficiency ever, so I think it's safe to avoid it, just to be on the safe side. I think
Thank you.
Doc Laster, you got something?
I do. I'll talk, I will piggyback on Dr. Pasricha talking about not recommending digestive enzymes. And the other thing I'll tell patients about probiotics is we have no idea if what they said is in the probiotic is actually going to make it to your small bowel to actually have any effect. The one thing I'll say about gluten-free diets, I think, is sort of twofold. I don't recommend sort of routines patients to be off of gluten. I think I do a deep dive into sort of patients who need to be on a gluten-free diet, which are those that have a wheat allergy or have celiac disease. And the reason I do that is because most commonly people with IBS will come in and say, oh, I've taken these things up, I've become restrictive, I've gotten off of a gluten-free diet. But what that means is you have to break that down, because it often means they've gone down the gluten-free aisle of the grocery store and they've picked up a bunch of processed foods that are all labeled gluten-free on the front of the label. And what that means is that, so now they think, oh, well, I'm perfect now, but why do I still have symptoms? Because I'm gluten-free. The celiac was stated, they do not have a wheat allergies. But like I talk to my patients it's not most likely the gluten isn't your issue. It's all the other crap that was in the processed food, all the emulsifiers, all of the additives, all of the other things they add in those foods to sort of make them shelf stable and to make them for the preservatives in them, to make them cheaper, to make them last longer. And so once I'm getting patients off of those sort of processed foods in general, they're able to recognize, oh, actually, when I eat, a chickpea pasta or a lentil pasta or something, or Ezekiel bread, you're right, I can tolerate that. I don't have bloating, abdominal pain, and those symptoms, because I think for most patients, it's not necessarily the gluten itself. It's really the other way we process breads and those sort of things here, with everything being degerminated. I think it's a lot of the processing and all of the processed foods and a bunch of, the foods that we eat in general, more so than gluten. Commonly, I'll have patients that say, you know what, I can eat pasta when I'm abroad, but not when I'm in the US. And that's because of the way our food is processed here. It's not sort of something that's sort of uncommon to hear. It's not surprising to me when I hear that. It's because of the food, the way our food is made and processed. And so I don't routinely tell people they should be on a gluten-free diet. I think patients take that to an extreme and they avoid sort of a bunch of things that are great for our guts and our health and overall health. And so I try to get patients to be on sort of, I sort of go through the detail of explaining what we mean. What is gluten? What's in processed foods? What are those pitfalls that we see on the front of labels? So we go through a lot of painstaking sort of time to talk about food labels. The front of the packet is all marketing, is what I tell them, that everything that says gluten-free, plant-based, vegan, soy-free, all these other things are just marketing ploys, low sodium, all this other stuff, low carb. What's really important is what's on the back. What does that ingredient list say? What is in that actual food? And so so that's sort of my take on gluten, especially as it sort of relates to GI symptoms in particular and overall health and obesity.
And the only thing I add is back to statins. The pressure, number one, we have to recognize every medication has side effects. So statins have side effects, muscle aching, insulin resistance, brain fog. Those are all in the package insert. I use statins when I have to at very low dose, sometimes 4 or 5 days a week, not daily. But the pressure is that the goal for a heart patient is to achieve a lower LDL. And it's hard even with a really, really good diet to hit those numbers. Used to be LDL cholesterol under 100, then LDL under 70, and now we're going to get new guidelines. The goal is to get LDL cholesterol under 55 to have the lowest risk of future heart attack and stroke. So if you're going to try and help your patient hit those targets, it's going to be a lot of things. It's going to be, the plant-based diet, the portfolio diet and everything, but you're probably going to need to sneak in a little bit of pharmacology here or there to hit a moving target, which is going down.
What nutritional supplements do you recommend to your patients, or do you not recommend nutritional supplements?
I can start from a GI perspective. I tend to have a lot of patients that come in on a ton of supplements. And I take the same approach as I talk about with probiotics and digestive enzymes, and to take a step back to determine, what do you actually need? What are you actually deficient in that you need to be supplementing? Trying to get most patients if you're on a pretty diverse diet that is well sort of with a bunch of fruits, bunch of vegetables and whole grains, the likelihood that you need sort of this supplements that patients come in with is unlikely. I talk to them about how supplements works, many of them being not FDA approved. So we don't know what else is going into them, what other chemicals, what else is being used to create those capsules and gels. And also many of them are water soluble. So they're like, oh yeah, I do urinate a lot. Yes, because you are getting rid of all of those things that you just spent a lot of money on to be able to obtain. And so I take a lot of time to check those things that are most commonly sort of deficient. A lot of my women iron deficient, so we check their iron levels. Do you need to be on an iron supplement? Vitamin D is also very common, so we test that. to look for the, are your vitamin D levels low? That's the thing that we sort of supplement. We check your calcium, magnesium, all of those things in sort of our routine labs, your B12, your folate, all of those common things to see if that's something that you need to be sort of supplementing. And because in some of our patients, that is, some patients that have had small bowel surgeries, who have Crohn's disease, who have celiac disease, these are things that put patients at risk to have certain deficiencies. So these are things that, we talk about in sort of in clinic, but sometimes patients will come in with a bunch of symptoms, and I see those symptoms in the medications that they're the supplements or the cause of some of those symptoms at times. Patient coming in with diarrhea and she's on magnesium 4 times a day. Well, that's the reason why you have diarrhea, because of the magnesium. So sometimes it's as simple as removing some of those things. I'm doing my training at a transplant center, seeing patients that have had to, that have been worked up for a liver transplant due to supplementation. So these medications, even though everybody thinks they're natural and they're, herbal and all of these, fancy words they use as, again, marketing, does not mean there's not side effects from those things that are potentially harmful. So definitely sort of getting patients to I go through those lists. What are you taking, even if it's over the counter, even if it's a natural supplement? What are you taking? What are you taking it for? Who told you needed to be taking that? And what are you actually deficient in? And how can we change that with your diet itself? And basically really sort of curtailing what you need based on actual deficiencies.
Thank you.
Yeah, I'll jump in. I agree with Dr. Laster, and particularly with the supplements, because supplements can be tricky, and we use supplements in a targeted fashion. We see a good number of people who are vitamin D deficient, and we actually have our own brand of supplements that we recommend. It comes from a known source that's tested, double tested in independent labs for impurities. And supplements, in my mind, by definition, none of them are truly natural because they're isolated nutrients. Now, we have to use them in a targeted fashion. So if someone has a very, very low vitamin D level, then we have to supplement to get it up. At the same time, we say, okay, eat mushrooms and get more sunshine. They're doing all of that at the same time. But we're very careful with supplements, and have a similar perspective as Dr. Laster, in the sense that we see a number of patients coming in with lots of supplements. And one problem with the supplements is they're not regulated. So many people are getting supplements over the counter, even from health food stores. And many of these supplements have more than what the so-called, recommended or proposed ingredient. And so have filler molecules and the like. And so these things could be hepatotoxic, they could be nephrotoxic, so they can have, adverse effects on the body as a whole. And we've had people come in on herbs or various supplements, have arrhythmias and different problems. So one thing we do is take them off supplements. And my concept is fairly simple. I thought the foundation of your nutrition should be foodaceuticals. So that's optimal nutrition. That's a plant-based diet. Next to that would be nutraceuticals as needed. And then above that, pharmaceuticals, if you're desperate enough, as a last resort. So your foundation always starts with food, and an optimal diet starts with what you don't eat first and foremost, as opposed to what you do eat. The biggest junk food eater in the world, every now and then, probably lets a piece of broccoli slip past their tongue. But it's the not eating of the bad foods. And so I think that's the most important part. And I seem maybe a little bit more cruel than some other people, but we have this concept, not a bite, not a drop, not a crumb, of any of these foods that are bad: dead animal flesh, processed chemicals, processed sugars, etc. And so we take that process approach first and foremost, and then we target supplements as needed. So we may use methylsulfonomethane or MSM, which is an elemental sulfur that helps the body produce glutathione, which is number one antioxidant. We may use concentrated curcumin, which is anti-inflammatory. Many of our people have inflammatory disease, arthritis, and the like. So we'll use that to decrease their pain symptoms, to avoid the need for non-steroidals or steroidal agents. We will use, as I mentioned before, vitamin D. We see lots of vitamin D deficiency. Oddly enough, we don't see a lot of people with B12 deficiency, but we use that as needed. We'll use liposomal vitamin C for people with atherosclerosis, people with inflammatory conditions and the like. and other supplements as needed. But again, we try to be very targeted. We will get special micronutrient testing from certain places where you can look at intracellular ions. Maybe the serum magnesium may be normal, but intracellular magnesium may be low. And so we may use a target magnesium supplementation. So we try to be targeted with it, but we try to do that on the foundation of an optimal nutritional regimen. And many of the symptoms will correct in that way, but not to overload people with supplements.
Thank you.
I'll just shout out on one. I am a supplement trained cardiologist. I've been through hundreds of hours of university training, but I'm very selective and I really try and keep my patients list down to 3, 4, 5. But I just want to mention coenzyme Q10. People on statins, if you study the biochemistry of the enzyme that statins interfere with, they also will lower the production of coenzyme Q10, an important antioxidant, important in the generation of ATP energy. And although there hasn't yet been a massive randomized study that if you're taking a Lipitor or Crestor, you ought to take a small or medium amount of coenzyme Q10, most of us that know the biochemistry think it's a reasonable idea and may help with tolerance. Coenzyme Q10 does support, there's studies that it raises ejection fraction in people with impaired heart strength. And then there's a randomized study in Sweden with 14 years follow-up that if you're a healthy 70-year-old on CoQ10 or placebo, you're likely to do better on CoQ10 in terms of cardiac events. So that is one that's widely available, extremely safe because the doses we use are a fraction of what have been used in some neurologic randomized studies with safety. But but don't put your patient on 50. I will say, last statement, most of the world's leading anti-aging experts, Harvard University professors, and I'll take 40, 50 vitamins a day. And, it's intriguing. I know what they're taking, but there's no proof. I'd rather they eat 40 or 50 different fruits, vegetables, grains, and legumes a day, but we haven't won them over yet.
Thank you. Dr. Bashira, did you want to add anything?
No, I think everybody covered it. And the only supplement that I also might consider that we haven't talked about in patients with irritable bowel syndrome, sometimes peppermint can be helpful to control some of their symptoms. And that, is per our guidelines that peppermint can help. So otherwise, I kind of agree with what other people have commented here, and especially what Dr. Laster said, is that I really try to minimize the supplements because we see it on the back end when patients are coming in with liver failure. So if levels are low, vitamin D, B12, then definitely they need to supplement. Usually B12 is kind of the most common one that I recommend, but otherwise I try to minimize supplements and focus on just getting the nutrients that you need from your diet.
Okay, great. If you would like to ask a question of the doctors, please click the reaction tab and click raise your hand. Dave, where are you from, and would you like to ask a question?
Yes, good evening. I'm from Canada, and my question is for the gastrointestinal doctors. What is silent reflux? What are its symptoms? What causes it? And what are the treatments?
What was the question? Was what is silent reflux?
Yes.
Okay. Well, that is something I see a lot when I have a patient that is sent from sort of ENT sometimes, where the patient will go in for hoarseness or some other symptom or cough. And during that sort of workup, they've been seen by an ear, nose, and throat doctor and had sort of an exam there first. And sometimes they'll see commonly redness on their vocal cords, and they say, well, maybe you're having silent reflux, right? And so the patient will say, well, no, I don't have any symptoms of sort of feeling like they have a sour sensation in my mouth. I don't feel food coming up after I eat. I don't have any symptoms of sort of that burning sensation. I don't have those symptoms. So that's why they'll get the name of sort of what is a silent reflux. Sometimes they're put on, by the time they see me, usually somebody has put them on an acid reducing medication, either a proton pump inhibitor or an H2 blocker. And usually are coming to see me to say, well, do I have this? What else do I need to do? And so what I do is a history first. What symptoms are you having? What prompted you to start having workup in the first place? And then we go down the road of trying to understand if you actually indeed have reflux. Sometimes patients will have an ENT exam, and just because you have, red vocal cords is pretty subjective sometimes, doesn't necessarily mean it's from reflux. So sometimes we'll do, based on symptoms, I'll get people off medications, do some dietary changes, talk about things that could possibly be triggers. Sometimes reflux can sort of have atypical sort of presenting symptoms, like waking up with a sore throat or having a sour mouth or cough. Or hoarseness or anything, one of those things. And so we'll do an upper endoscopy first to see if there's any sort of damage to the bottom of the esophagus that can be caused by sort of a constant acid exposure called esophagitis. And there's a grading criteria that we have. If a person has a hiatal hernia, they're sort of more at risk for having sort of their bottom of their esophagus sort of bathing in that acid. And sometimes doing sort of some specialized testing like Bravo studies, which is a little camera, a little test that we can sensor, we can put in the bottom of the esophagus to measure that acidity as well, or a pH impedance probe, which also patients, this one's a little bit cooler because you can press a button when a patient has both, actually, when you have symptoms, and it sort of can send that will be able to measure exactly what your pH is at that time, to be able to correlate as when you're having symptoms in actual time and when you have a very low pH. This is how we're able to decide if your symptoms that you sort of initially presented with are actually due to acid reflux or not. And so I think that is what's commonly sort of known as sort of silent reflux. There's also other sort of things that talk about non-acid reflux as well. So that is when we use those similar tests to determine if what patients are feeling is actually due to sort of acid, or is it just a sensation where they're hypersensitive, where they feel something going up into their esophagus, but it's not actually it's something that's acidic.
And just one thing to add to that is that if there's a concern about silent reflux, or ENT does see something and there's concern of reflux, if we do an endoscopy, which we usually will, if there is something called Barrett's esophagus, those are cell changes that occur in the bottom of the esophagus that put you at increased risk for developing esophageal cancer. So many patients might have silent reflux, but they're actually having acid events that are affecting the esophagus. And those cell changes can be quite dangerous. So it just needs to be monitored closely on the right medications and repeat endoscopies to make sure that it doesn't turn into esophageal cancer.
Alejandro, would you like to ask a question, or where are you from?
Hi, thank you. Thank you all for being here, sharing your time with us. I'm in Illinois, United States. And my question is, can you give any insight on sweeteners and the relationship with good and bad bacteria, especially sucralose? Thank you.
Well, I don't know if I can comment specifically on sucralose, but we do know that any sort of refined sugar, excess sugar, that does pose an increased risk for developing worse bacteria. There are studies that show that any artificial sweeteners, anything in, for example, Diet Coke, Diet Pepsi, all of those artificial sweeteners do negatively affect the gut microbiome. So as much as possible, I do recommend just avoiding as much processed sugar as possible. I don't know if you have anything more to add on that, Dr. Laster.
I would echo the same thing. I talk about there's studies that show sort of the changes in microbiome from sweeteners in general, and also the symptoms that patients get caused as well, like bloating and that sort of thing. So I just try to get people to avoid sort of artificial sweeteners in general.
There was an article presented this week on sucralose and aspartame inhibiting liver detoxification pathways. It was actually presented at a GI meeting. So just one more nail in the coffin of yellow and pink packets, blue packets.
Raymond, would you like to ask a question, and where are you from? Raymond, would you like to ask a question?
And so if you could just do me a favor.
Raymond, would you like to ask a question?
Trying. Yes, can you hear me?
Yes.
Yes, I've heard the doctors talk much about the gut microbiome. Can you be a little more specific in talking about how important that is? Because I've heard, even just now, you just mentioned that. So two of you did. So can you talk a little more about that?
Sure. So, you know, as new research is coming out, the gut microbiome is, you know, a really hot topic. I would feel like every day there's new research articles coming out about how the gut microbiome is affecting not just GI illnesses, but I feel like it's basically been linked to any chronic medical condition. The gut microbiome has been linked to cancers, lung disease, atherosclerosis, arthritis. So, you know, I feel like, you know, this might be my bias, but as a gastroenterologist, I really believe that the gut microbiome is the biggest proponent in developing chronic medical issues. And if we can take good care of our gut microbiome, then we are putting ourselves at best chance for staying healthy and having less risk for inflammatory conditions down the line. You know, we've talked a lot about how diet affects the gut microbiome, that we know processed foods, animal products, sugars negatively affect the gut microbiome. One thing we've not talked about is that the gut microbiome can really rapidly change. So this is not a quick change or fad diet. This needs to be consistent lifestyle change. Research has shown that if you change your diet and you transition toward a plant-based diet, we can see effects in the gut microbiome within just one day. And we've also seen, conversely, that in research trials where people go back to their normal routine diets afterwards, that within just a day or two, their gut microbiome reverts back to the way it was before. So we do know that diet makes a huge difference in the gut microbiome. Consistent, healthy eating, plant-based, diversity of foods will improve your gut microbiome. And I really feel like the research is, you know, every day there's like dozens of articles coming out just supporting the fact that the gut microbiome is linked to every chronic inflammatory condition that I can see. So if anybody knows of a condition where the gut microbiome is not impacted, you know, I would love to know that. So.
Tracy, would you like to ask a question, and where are you from?
Yes, I would like to ask a question. I'm from Florida, and I wanted to know, I'm a plant-based healthy eater. I don't eat any animal products with the exception of sometimes sardines or eggs. And that's like maybe twice a week. And I was wondering, my cholesterol has been historically high in that my LDL has been high, my total cholesterol, and yet my ratios, and this is a question I have, am I looking at these total numbers, or are ratios, how does the panel feel about ratios like triglycerides to HDL or total cholesterol to HDL, those ratios? And then one last thing is my fibrinogen has been over 300. And where does that play a role in atherosclerosis, perhaps?
I'll volley in as Dr. Kahn. You know, the problem with the ratios that involve HDL, and clearly a higher HDL creates a lower ratio, which is healthy, and a low HDL creates a higher ratio, which is unhealthy, is generally the cardiology community has put a hold on using HDL as a predictive biomarker. It used to be simple from the Framingham study: low HDL risky, high HDL protective, but there's total confusion in the literature. There's many case series of people with high HDL and premature hardening of the arteries. So if you rely on the ratios, you're buying into old science, and the current guidelines don't emphasize anything about HDL measurement, HDL treatment. It's good to exercise. Maybe have a glass of red wine 1 or 2 times a week if you like or not. That may raise your HDL, but there's really no emphasis on it. So I think it's obsolete right now that we get better tests. I think your total cholesterol and your LDL cholesterol are where you ought to emphasize, and talk to your doctor if you've never had a coronary calcium CT scan. If your score is 0, you don't need aggressive therapy. If your score is 389, you need to find a lipid expert, cholesterol expert, preventive expert, Dr. Montgomery expert, and figure out a natural or a dietary or a pharmaceutical way to change your numbers.
Yeah, and I'll add to that. I agree with the issue of ratios, but I'll also add, whenever your numbers are not optimal, even on the healthy diet, you just need to, just like we'll increase the dose of a medication, you need to increase the dose of your diet. So I would say the total elimination of all animal products, including eggs or sardines or whatever animal products someone's eating. And if that doesn't work, I would go to a raw diet with time-restricted eating. So it's sometimes people come in with say, I'm eating the best diet, and you're right, you're eating, a good diet, but maybe you just need to tweak it a little bit. And sometimes you make very small changes, you can get very big results in your overall biochemistry. So I would start there typically with my patients in making those extra dietary changes to be more precise. And we do food dietary histories and the like.
Brenda, would you like to ask a question, and where are you from?
Thank you. I'm in Washington, D.C. And there were a couple quick questions just as a reminder. What was the name of the cardio examination that was like under $100 that the cardiologist recommended? Just maybe the name of that exam. That's not my question, but just trying to remember the name of that exam.
Yeah, probably the most frequent abbreviation is CACS, coronary artery calcium scan, or coronary artery calcium score. You can do it either way.
Thank you. And I just wanted to find out from each panelist if there was one change. I know people mentioned the raw food diet or mentioned fiber, et cetera, but in your particular area of expertise, if there was one thing someone wanted to do this week to get to a healthier gut health or better heart health, what would be your recommendation based on what you've seen is helpful in general for most people?
I can start from a GI perspective for as far as the most common symptoms we see being sort of bloating, abdominal discomfort, constipation, and in my practice, obesity. And I would say that one huge thing for me is getting patients to drink water. If I can get patients to actually to sleep and to drink water and sort of to remove sugary beverages and sodas, that way, if I could only choose one thing, that's usually where I start. I get people to drink water.
I'll jump in. I would put them on, if they to do one thing, sort of a collective thing would be to go on a raw plant-based diet with time-restricted eating. We do that first and foremost with patients. I agree with the water component because water is probably the most important nutrient. If someone's consuming all their plants raw, if you're eating cucumbers and lettuce, carrots, etc., those plant foods in their natural states are like 80–90% water. So you're eating a lot of your water in addition to the water you drink. And so 90% of your consumption is going to be water with the micronutrients, phytonutrients, fiber, and things that goes with those raw plant foods. But I would do that with time-restricted eating because that increases your fasting window. So we do like eating from say 10 to 5 or 11 to 4, 11 to 5 is your feeding window of raw plant foods, and the rest of the time water while you're awake and sleep while you're asleep.
Sarina, you want to jump in?
Sure. I mean, it's so tough to just say one thing because really it's minimizing and eliminating the processed foods and animal products. And instead of, eating those things, substitute it with fruits, vegetables, and whole grains. It's really kind of a switch. When you take something out, you need to put something in because the goal is not for you to be hungry and starving. So minimizing the processed foods and animal products. If there was, like, if I had to just give one food item to eliminate, I would say for me and my patient population, dairy causes the most issues. Dairy causes a lot of inflammation, bloating, gas. A lot of patients have lactose intolerance. So if it was one swap that you're looking for that's super, I think, easy, is eliminate dairy and swap it with a plant-based milk and cheese. But you're asking a tough question. It's not easy to answer.
And Joel, Kahn, I was going to bring up dairy, so thank you, Sarina, because there is an easy substitute. And so my answer would be stop eating processed meat, which the World Health Organization says causes colorectal cancer. The Gates Foundation says is the #1 food that predicts shortened lifespan, and it is tightly linked to cardiovascular disease, congestive heart failure. But then you got to come up with a substitute, and I don't want people eating, plant-based sausages long-term. It's an acceptable short-term switch if they're not very sick. So stop eating bacon, start eating a salad. It's not exactly an equivalent switch though.
Gregory, would you like to ask a question, and where are you from?
Yes, I would. Can you hear me?
Yes.
Yes, I'm Gregory Jones from Plainfield, Illinois. And I've noticed certain foods over the years give me joint pain and mucus and cause me to have a runny nose. So I assume I have a food sensitivity. I want to know if that assumption is correct. And if so, also I've heard of the term leaky gut. So I'm wondering if that also means I have leaky gut. And if so, how do you test for leaky gut? How do you get tested for that?
Okay, so I can talk about, so leaky gut is kind of what people in the lay public talk about, but we don't really use the words leaky gut in our GI literature. People who get leaky gut usually have abnormal gut bacteria and gut bacterial dysbiosis. When you get abnormal gut bacteria, the layer of cells that is there to protect you from your gut into your blood, the gut-blood barrier, that becomes weakened. And that's something called gut permeability. That's what we kind of say for leaky gut. Basically, the bottom line is if you think you have leaky gut, it's probably that you have unhealthy gut microbiome. And the best way to fix that is to change your diet and lifestyle. That's kind of like a short answer for that. And then food sensitivities, we are seeing a lot more patients come in with food sensitivities. I think I like that you say food sensitivities. Some people mischaracterize it and they think they're allergic to foods. An allergic response is very different than a sensitivity, just in the immune system and the way that allergies are immune mediated, IgE mediated. So food sensitivities means you don't tolerate it well. But what I like to talk to my patients about is that it might not be that you are sensitive to that specific food. It might be that your gut microbiome is altered, it's not working properly. So right now you can't tolerate that specific food. It doesn't mean that you can't tolerate that food in the future. If you can work on your gut microbiome and make positive changes, many of those patients that I see that have a food sensitivity and can't eat certain foods, they're eventually able to eat those foods without any problems at all. Just remember your gut is a muscle. It needs to be used. It needs to be trained properly. And for most people, we've been training it wrong for many years, even decades, by eating the wrong food, not getting enough sleep, not exercising enough, consuming too much alcohol. We're training it in a wrong way, and now we have to retrain it. And it's not always easy. Just trying to get your gut microbiome healthy, making a switch to a plant-based diet, that alone can cause some bloating and gas. That should not deter you. That is part of the process of when you switch and transition to a high fiber diet, there can be some uncomfortableness and discomfort, but keep persevering and keep trying to do what you can to improve your gut microbiome, because many food sensitivities will go away if you have healthy gut microbes.
Great. If each of you would make a closing 30-second statement to wrap up any final thoughts, and also let us know what's the best way to get in touch with you. Also, for all of our listeners, if you go to our website and you click on the bio of any of these speakers, it'll take you to the website and what they are mentioning now. But if you could just tell us the best way to get in touch with you, your books, your website, and if you offer Zoom appointments, if each of you could just take 30 seconds to give a closing statement and tell us how to stay in touch with you.
Sure. Joel Kahn, I'd say the most powerful tool for prevention and healing is to master lifestyle medicine, focusing on nutrition, and do it early in life as possible. I can be found on my website, drjoelkahn.com, drjoelkahn.com. I'm licensed in most states in the United States, and I do telehealth, but I have an active live office. Just fly to Detroit. It's wonderful.
Thank you.
Janese Laster. I would say for my closing remarks, let's see. Whatever symptoms you're having, whether it be GI symptoms, whether you think it's something embarrassing, if it's stool related, if it's excess weight, difficulty with weight loss, talk to your physicians about it. Let's just get it out. You can talk to us about anything, and let's find you a solution. And I can be found in Washington, D.C. I do see telehealth patients in the states where I'm licensed, about not as many as Dr. Kahn, but maybe about 8. And you can find me on, or you can come to DC. It's fun here. And find me online at guttheoryhealth.com.
Thank you.
This is Sarina Pasricha. Thank you for having me on. If I can just kind of leave one thing, it's just remember that your gut, those gut instincts that you have, those feelings are real. What's going on in your GI tract is going to affect your mood, how you feel, the energy level you have, and vice versa. The stress, the anxiety that you're feeling, or the happiness and joyfulness that you're feeling will in turn affect your GI tract. They are linked. Don't ignore those. And just remember that the key piece to all of that is your gut microbiome and the invisible bacteria. You can find me on my website, www.docsarina.com, Doc Sarina. And I'm on Instagram and Facebook at Doc Sarina, DOC-SARINA. Sign up for my newsletter to be coming soon. And I only see patients in person, so you'd have to come to Delaware, but I'm happy to see you. So thank you.
Thank you.
Baxter Montgomery, and my final comments are simply, optimize your life, and optimize your life, you need to optimize your health. To optimize your health, you need to optimize your lifestyle. That's going to start with your nutrition, proper sleep, exercise, healthy relationships and the like. Be mindful of your vices and go toward those vices and attack them first and foremost. I can be reached online at montgomeryheart.com. That's montgomeryheart.com. You go to our website, and there are a lot of programs and things. We see patients here in Houston. The Texas Medical Board allows us to see patients nationally if you've made an initial office visit here in Houston. And we have patients across the country who see us through remote. We have a digital health clinic. We also have online wellness programs. And if you go to montgomeryheart.com/journey, you can learn about our online health programs, our healthy lifestyle series coaching program, and our community that we have that help people come together and optimize their life.
You've been a great panel. We're very grateful. Please unmute the audience so we can all thank them together.
Thank you.
Thank you.
Thank you.
So much.